Hello everyone, my name is Karan Chabra. I'm one of the third year internal medicine residents at Beaumont Hospital, Royal Oak in Michigan, and I'll be presenting a case of complete heart block that got complicated by polymorphic VT, that is Torsades de point. So the aim of presenting this case is the importance of recognizing the presence of ventricular ectopic rhythm in patients with high-grade AV blocks or complete heart blocks because it can degenerate to polymorphic VT or VFib. And this usually responds to timely pacing, whether transvenous or a permanent pacemaker. So coming on to the case, we had a 74-year-old female patient who only had past medical history of hypertension. She initially presented to the emergency with chief complaints of syncopal episodes. Interestingly, she had 3 such episodes in the last 2 days prior to presentation, and she never had any prodromal symptoms. When she came into the emergency, her heart rate was in the 30s, her blood pressure being around 220 by 110s, and her EKG showed high-grade AV block, mostly complete heart block. Her lab work was significant for hypomagnesemia at 1.5, and her serum potassium was 3.7, so kind of low normal. She then proceeded to have multiple runs of non-sustained polymorphic VT on the TMS, and this was thought to be precipitated by R-on-T phenomenon within her underlying complete heart block. Now, given her low magnesium, we proceeded to supplement IV magnesium, and we also put a transvenous pacemaker as the patient came at night, and she did have complete heart block that was symptomatic. The TVP threshold was adjusted to overdrive her native underlying rhythm, and after that the runs of VT subsequently resolved. She then underwent a dual chamber permanent pacemaker placement on the next day, and after that she didn't have any repeat episodes of VT after the pacemaker insertion. So coming on to the discussion, marked bradycardia or high-grade AV blocks are known to be associated with QT interval prolongation, and that can also extend the duration of ventricular action potential. This phenomenon can increase the risk of an extra stimulus, which can trigger PVCs even before the ventricular action potential repolarizes. And if in such a case a timely PVC occurs, functional block can cause re-entrant excitation, which can lead to polymorphic VT or VFib. So to conclude, prompt recognition of R-on-T phenomenon as the insult for ventricular arrhythmias in patients who initially present with complete heart block, it can help stratify appropriate treatment. And these patients should not be given antiarrhythmics initially, given that it will worsen the block, and it therefore emphasizes the importance of immediate pacing to overdrive, suppress the underlying ectopy and AV dissociation. Thank you.